Welcome to Why We Must Change the Conversation Around Opioid Treatment. Thank you for coming. We're fortunate to be part of a community that is invested in coming together and working on tough problems. We're grateful for the participation of each of you in this event, and we're fortunate to have a panel of community and provider champions who will be presenting and answering your questions today. My name is Eric McNair Scott, and I'm the project lead for the opioid response work of the Southwest Accountable Community of Health, otherwise known as SWACH. Slide. There we go. So the opioid epidemic has touched us all. It's had a devastating impact on our friends, our family, our communities. It's the biggest public health epidemic in our history. And when you look at overdose deaths, we do not seem to be coming out of it. Center for Disease Control says that the epidemic continues to worsen, and you can see the numbers of opioid deaths over the last 3 years. Slide. But OD deaths are just the tip of the iceberg. For every single death, there are many more people admitted to hospitals and EDs, and many more who have opioid use disorder, and many more still who use opioids non-medically. In Washington, the iceberg played out like this. With 694 opioid-related deaths and 259,000 people in our state in 2016 who use opioids non-medically. So what is SWACH, my organization, and how does it fit into the work we are doing to respond to the opioid epidemic? SWACH is one of 9 organizations across Washington called Accountable Communities of Health that are working to transform healthcare. We're working with partners in our community and healthcare systems to support better care, that's for individual patients by treating the whole person, better health outcomes for the community as a whole, and at lower cost. We need to be able to do all this so healthcare costs less. Our healthcare system is currently the most expensive in the world, but it's not giving us the results we want and need. We can and must do better. We think one essential way forward is through collaboration, learning together, as we're doing today, solving problems together, and creating partnerships across settings and with community partners. We know that the sum can be greater than its parts, but the parts need to work together. So collectively, we can improve the health of our community. So that's not a new idea, but it's just never really made much sense as a business model. So, there's been no money behind it. What's new now is that there's funding to support this. There is money coming through the Medicaid Transformation Project, and there is money coming through the coming shift in how Medicaid will reimburse providers through a value-based payment structure. So let me explain. SWACH and all of the accountable communities of health are working as part of the Medicaid Transformation Project. The Medication Transformation Project is a 5-year agreement between the state and the Centers for Medicare and Medicaid Services to provide federal money to transform health systems and benefit Medicaid clients. Through the Medicaid Transformation Project, Washington can access up to $1.5 billion with a B dollars for this work. So that's a significant chunk of change. As much as I do not want to reduce the devastating impacts of the opioid epidemic to finances, I am going to talk about the money side of this work before we come to our panelists. Because we know that money can drive change, and opioids is a very expensive epidemic. So let's go back to that iceberg. Think about the costs of everyone involved in each level of that iceberg. The treatment admissions, the ED visits, each level has a cost associated with it. The cost of the country's opioid crisis is estimated to have exceeded $1 trillion with a T from 2001 to 2017, and it's projected to cost an additional $500 billion by 2020. Beyond healthcare costs, there are opioid-related costs associated with lost wages, lost productivity, lost tax revenue, social services, education costs, criminal justice costs. And if we look at the healthcare costs, costs of emergency room visits, costs of ambulances, costs of the other health problems that can develop when you have an opioid use disorder. Next slide. The cost has been calculated at $215.7 billion since 2001. And the question we can ask is whether we've been using these dollars in the best way possible to support and treat people with opioid use disorder. Next slide. Is there a better way than spending money on all those ED visits and ambulance responses? Which brings us to value-based payment. Value-based payment is a major shift in how healthcare providers serving Medicaid clients will be reimbursed. The Medicaid Transformation Project is designed to support providers in transition to a value-based payment model. Right now, the primary mode of payment is fee-for-service. This means that a provider is paid a set amount for a service, treatment, test, or procedure. As a financial model, this incentivizes volume. The more treatments, the more services, the more you are reimbursed. The more ED visits and ambulance responses for people with opioid use disorder, the more you are reimbursed. Just as important, the model discourages providers from participating in activities that encourage care coordination and whole person approaches to care because these approaches don't pay or they don't pay much. So next slide. Providers in a hospital may want to help the person with opioid use disorder get mental health services or treatment support, or get hooked up with social services or housing support, but their reimbursement model does not support this. Fee-for-service pays for volume. In contrast, the value-based payment model reimburses providers for improved population health outcomes. It pays for value instead of volume. Great, so how do we get there? We need to shift our thinking because value-based payment relies on system-wide, community-based collaboration. Research suggests that only 20% of a person's health is determined by the medical care he or she receives, so medical settings aren't going to get there alone. The other 80% is determined by social factors such as access to healthy food, access to transportation, housing, where you live, your health behaviors, and other factors. And these 80% are called social determinants of health. And if you're a healthcare provider, value-based payment means you now have a financial motivation to help your patients with these social determinants of health. And you will not be able to do that alone. Collaboration in creating partnerships across settings and with community partners will be required to transform our health system from fee-for-service to value-based care. This is where the Medicaid Transformation Project and SWACH can support change. The transformation will support care that focuses on the whole person and supports the development of healthier and better integrated communities. When it comes to opioid treatment, we must support better patient care, better health outcomes, and the lower cost of care. So now, I'm going to turn it over to Selina Meyer. And as we dive deeper into why we must change the conversation about opioid treatment, please think about how the Medicaid Transformation Project and the shift to value-based payment can create the opportunities for collaboration and new partnerships to support the work ahead. Thank you.
Thanks, Eric. My name is Selina Meyer, and I am the chair of a local prevention organization called Connect Evergreen. It's one of several regional youth substance abuse prevention coalitions in our area, and I see some of our friends here today. Connect Evergreen serves the population that is living, working, or going to school within the boundaries of Evergreen Public Schools. But we're also part of a bigger system, and that system is really devoted to bringing trauma-informed approaches to prevention. So instead of the DARE models that most of us grew up with, we're looking at how trauma is a social determinant and an environmental determinant of whether a young person gets involved with substance abuse. That's complicated stuff for most people to wrap their heads around. And it's complicated because we don't necessarily easily make the connection between how a young person connects with their family, school, community, and how trauma gets in the way of all of those things. So when we talk about all of these pieces of social determinants of health and these pieces of connection, we have to understand that people get to addiction in lots of different ways. And when it comes to opioids specifically, most people get there through trauma first or prescription second. Most people didn't go to a party and just go too far over and over and over. That's not how that works. But that's what the stigma that's out there keeps telling us. So we have to accept a couple of big realities. And the first big reality is that people get to addiction through many paths, and that trauma is the primary pathway or gateway to addiction. And the hard part of that is it doesn't get just in the way of young people or adults connecting to services. It gets in the way of their mental, emotional, and physical health. Trauma, which you're going to learn more about from Lydia in a little while. Trauma affects our ability to connect in with relationships, connect in with ourselves. It gets in the way of the skills that young people and adults develop in navigating complex systems or making complicated decisions. So when we have those early moments of abuse and neglect, of household dysfunction, it doesn't just change how our outlook is to the world. That's a big piece of it. But it actually rewires our neurobiology and gets in the way of us being able to make decisions about really important things. It hurts us and it creates barriers to healing. So it's that reinforcing cycle. But there's hope. Because community, more so than we've ever known before, we know that community creates resilience and reconnection. One of the best pieces of research that's out there comes out of, I believe it's Walla Walla, and a couple of other Washington cities and counties, that showed that even if a person has really low resilience individually, measured by some pretty standard resilience factors, even if they are really, really low on that spectrum, if the community that they're in exhibits high levels of resilience measures and things like reciprocity, collaborative services, all of those things that add up to a supportive system, then not just the best situated folks in that community do better, but even the worst situated folks in the community do better. It turns out that community resilience is a bigger indicator of recovery and restoration and healing than individual resilience has ever been. We need both. But where we individually can fall short because life hands us stuff, that's where community can fill the gap. Community connection is our primary gateway to effective recovery. Not just recovering from trauma, but also recovering from opioid use disorder or any other substance use disorder. Community reconnects us to others. It reconnects us to the health and support systems that we need. Pardon me. It teaches us the skills to improve our decision-making and our own outcomes. And without supportive systems of care, even the most resilient people who are looking at recovery and trying to walk through that transformative process can face extreme difficulty. Even the strongest of us, without a support system, are still facing stuff that we can't get through on our own. Here's the thing. When somebody's facing any substance use disorder or any recovery process, there's piles of stuff that you have to go through. And what we know now after decades of research and decades of failing systems is that stigma is a barrier that keeps people from recovery because it is keeping them from everything that recovery is: support, services, medical care, and connection. It keeps people from accessing what they need. It keeps other people from helping them. If I'm walking through those things and I need my support people and they're thinking it's a moral failing that I have gone down this path and made these choices. Well, that stigma, that idea that this is somehow a bad person doing a bad thing, ignores all of the research that we know about neurobiology, about psychology, and about how people get to where they get. But it's really important that we understand that stigma does one big thing that's pretty quiet and very, very prevalent. It also keeps providers from treating people appropriately. And that's a hard pill to swallow. When we can acknowledge that stigma is one piece of a giant pile, right, of things that we have to dig through, that's sitting at the top. And once we take it off, then we can actually get to addressing the real issues that are underneath it. But it in itself is an issue that the stigma that is out there affects providers and their ability to connect with patients. Now, providers have some really valid concerns about treating people with substance use disorders, or especially opioid use disorder, because there can be some negative impacts with treating that population. But as valid as those challenges are, we have to understand that opioid use disorder as a chronic brain disease requires more skills to treat the population. And not just more skills from medical providers, but from peer providers, from communities, from prevention organizations, from teachers, from parents, from church members, from all of us. Today, we're going to learn more about the supports and tools that are available. And for providers especially, we're going to learn about 4 really important things that help us not just change the conversation, but change the system. You're going to learn today, and I have to warn you, I'm going to pause. You're going to get fire hosed today. There's muffins, because your brain's going to need some food. There's coffee, because right? Some of us brought energy drinks, and Dr. Melnick's in the room, and there's some other public health people who are looking at me right now because I said energy drinks. We'll have that conversation another time. But you're going to get fire hosed. You're going to need to take lots of notes. And this is day 1 of a long and powerful conversation. But for today, the 4 things that I want you to keep thinking about and writing questions down, and there's actually another 5 things too, so there's going to be 9 things, and then there's going to be some more after that. But 4 things to start with. Our knowledge about opioid as a chronic brain disease. Not unlike heart disease or diabetes or any other thing that affects an organ in our body, this is a chronic brain disease. You're going to learn about strategies and programs that we know work, and it's different than what we ever thought was possible before. Some of us are going to be really challenged by some of the models that we're talking about today. That's okay. You're going to learn about a framework for understanding trauma-informed care at a little bit deeper level and its implications for treating opioid use disorder. So when we talk about trauma-informed care, it means a whole lot more than bedside manner. It means a whole lot more than changing the paint and the decoration in an office. It means a whole lot more than asking someone what their ACE score is. Trauma-informed care means we change how we do the whole thing. You're also going to learn, as Eric mentioned, about supports that are available so patients and providers can actually benefit from a peer-integrated treatment model. So we're going to go brain disease, trauma-informed care, peer integration. And so for the next 2.5 hours, maybe longer, so plan to stay late, just plan for it, if you can. We're going to go in and dive deep. We're going to challenge some of our own stigmas and our own perceptions about what opioid use disorder really looks like and what treatment really should look like. We're going to remember that there is more than one path to recovery. And hopefully at the end, you're going to have more questions than you do now. Sound good? Yeah. Okay.